We are going to start the test and discussion. So have a look of this question. Which of the following combination is incorrect? Greenish nipple discharge in ductictasia, microdocectomy performed in duct papilloma, Hadfield's operation, ductictasia, Grumman's discharge, fibrocystic disease. Now let's have a look of each and every option. First option, greenish nipple discharge is seen in ductictasia. This is correct. You must be knowing that in ductictasia, any kind of nipple discharge is possible. Bloody nipple discharge, serous nipple discharge, greenish, blackish, grumous or pultaceous nipple discharge. So all kind of nipple discharges are possible in ductictasia. Second, in duct papilloma, there is bloody nipple discharge. And what is the treatment of duct papilloma? It's the excision of involved duct only. And excision of involved duct is known as what? Microdocectomy. So this option is also correct. Now third, Hadfield's operation. This is performed for ductictasia. What is Hadfield's operation? It is conical excision of involved duct. So it is performed for ductictasia. And if you are looking at the fourth option, Grumman's discharge. Grumman's discharge is also seen in ductictasia. It is not seen in fibrocystic disease. So question is asked, what kind of discharge is seen in fibrocystic disease? Here, there is serous discharge. There is serous discharge. So let us quickly see the etiologies of nipple discharge. Bloody nipple discharge is seen in duct papilloma. Other causes are carcinoma and ductictasia but the most common cause is what? Duct papilloma. After that, serous nipple discharge. This is seen in fibrocystic disease, which is the most common cause. Other causes are carcinoma and ductictasia. Carcinoma and ductictasia. And third is greenish, blackish, grumous or pultaceous nipple discharge. This is seen in ductictasia. So what are the questions which are frequently asked about this? That what is the most common cause of bloody nipple discharge? That is duct papilloma. Most common cause of serous nipple discharge, that is fibrocystic disease, and any kind of nipple discharge is possible in ductictasia. In duct papilloma, we performed excision of involved duct only, that is microdocectomy. In ductictasia, we perform Hadfield's operation. It's the Hadfield's operation. Now see this question. Which of the following is not the risk factor for carcinoma breast? If you see first option, BRCA mutation, it is the risk factor for carcinoma breast. Hormone replacement therapy, it's a risk factor for carcinoma breast. Previous benign breast disease, it's a risk factor for carcinoma breast. But personal history of carcinoma cervix is not the risk factor. What is the risk factor for carcinoma breast? Personal history of carcinoma ovary, carcinoma endometrium, carcinoma ovary, carcinoma endometrium. Why? Because these are the malignancies which are adenocarcinoma. Usually adenocarcinomas are more common in high socioeconomic status. Can you see? Carcinoma cervix is squamous cell carcinoma. One of the risk factor is human papilloma virus, and it is more common in low socioeconomic status. So what is the correct answer for this question? The correct answer is D. Personal history of carcinoma cervix is not the risk factor for carcinoma breast. The question is pre-malignant lesion with high risk for malignancy. See, first D, it's not having high risk for malignancy. Ductictasia, not having high risk for malignancy. Sclerosing adenosis, not having high risk for malignancy. Atypical ductal or atypical lobular hyperplasia is having high risk for malignancy. This is very, very important. So now see the list of breast disorders which increases the risk of breast cancer. So here you can see if there is non-proliferative lesion of breast, there is no increased risk. Sclerosing adenosis, intraductal papilloma, again there is no risk. If there is florid hyperplasia, 1.5 to 2 fold increased risk. Now you can see this is the frequently asked question, that in atypical lobular hyperplasia and atypical ductal hyperplasia, how much is the risk? It's 4-fold increased risk. After that, this is another frequently asked question, that ductal involvement by cells of atypical duct. Now this is frequently asked question, that ductal involvement by cells of atypical ductal hyperplasia, how much is the risk? It's 7-fold, and maximum risk is there for lobular carcinoma in situ and ductal carcinoma in situ, and that is 10-fold. So this table is very, very important, frequently asked in exam. Before coming to this question, there are certain one-liner questions which are frequently asked about carcinoma breast. So what are those one-liner questions which are frequently asked? First, that what's the most common histological type? The most common histological type is adenocarcinoma. Question, what is the most common histological subtype? Most common histological subtype is invasive ductal cancer. After that, what is the most common site of breast cancer? If this is the breast, most common site of breast cancer is upper outer quadrant. Why? Because there is maximum amount of breast tissue in upper outer quadrant. Question, what is the least common site of breast cancer? It's the lower inner quadrant. Why? Because least amount of breast tissue is there in the lower inner quadrant. After that, best prognosis is seen in tubular variety. Best prognosis is seen in tubular variety. Worst prognosis is seen in inflammatory breast cancer. Most common histological subtype is invasive ductal cancer. Least common type. What is the least common type of breast cancer? And that is papillary. Least common type is papillary. How to remember? Most common type of thyroid cancer or carcinoma thyroid is papillary. Least common type of breast cancer is papillary. So this is how you will remember. After that, what is the most common site of metastasis? It is bone. What kind of secondaries are seen? Both osteolytic as well as osteoblastic. What kind of secondaries are more common? It is osteolytic. And one question which was asked in latest exam, that Batson plexus is involved via which vein? It's the anterior intercostal vein or posterior intercostal vein? Be careful. It's the posterior intercostal vein. So now let's have the look of all the options. If you see first, least common site lower inner quadrant, this is correct. Batson plexus involvement by anterior intercostal vein, this is wrong, because this is because of posterior intercostal vein. Best prognosis is seen in tubular variety, and most common site of metastasis is bone. So for this question, what is the correct answer? The correct answer is B, that Batson plexus involvement is by anterior intercostal vein. It is because of posterior intercostal vein. Now this question was asked indirectly in AIMS November 2018, and the question was, what's the most conspicuous sign of breast cancer? The most conspicuous sign of breast cancer is what? Pudy orange. So this option is correct. Dimpling as well as puckering, both are because of involvement of ligament Cooper. So here you can see this dimpling. This dimpling is because of infiltration of ligament of Cooper. This is correct. Puckering is because of involvement of ligament of Cooper. This is also correct. So what is the correct answer for this question? All of the above, because pudy orange is most conspicuous sign of breast cancer. So all the options are correct. This is one of the very hot question. Nowadays, it's frequently asked in both surgery as well as in radiology, that how much is the radiation dose in mammography? It's 0.1 centigrade per study. The radiation dose in mammography is 0.1 centigrade per study. Question: what is the investigation of choice for screening of breast cancer? That is mammography. At what age screening should be started? It should be started at the age 40 years of age. So mammography should be started in all the females at 40 years of age. And after that, annual mammography is recommended. Questions are asked that what is the first investigation done in a suspected case of breast cancer? The first investigation done in a suspected case of breast cancer, that's mammography. What is the investigation of choice for diagnosis of breast cancer? That's biopsy. Investigation of choice for diagnosis of breast cancer, and that is biopsy. Question: investigation of choice for screening of breast cancer in high risk females. In high risk females, and that is MRI. So these are frequently asked questions related to investigations in carcinoma breast. So for this question, correct answer is C, that is 0.1 centigrade per study. Question is, which of the following is seen in carcinoma breast? Powdery calcification, be careful, it is seen in fibrocystic disease. Powdery calcification, fibrocystic disease. Popcorn calcification is seen in fibroadenoma. And this pleomorphic calcification is seen in carcinoma breast. So pleomorphic calcification is seen in carcinoma breast. See the various types of questions which are asked about calcifications detected in mammography. Now here you can see in carcinoma there is microcalcification, punctate or branching calcification, and all these are pleomorphic calcification. So microcalcification, punctate, branching calcification or pleomorphic calcification, this is seen in carcinoma breast. In fibroadenoma there is popcorn calcification, whereas in fibrocystic disease there is powdery calcification, and in cases of fat necrosis there is curvilinear calcification. Question is asked how you are going to differentiate microcalcification from macrocalcification. In macrocalcification, the size of calcification is more than 0.5 mm. In microcalcification, the size of calcification is less than 0.5 mm. This question was asked in a latest exam, that what is the risk of malignancy in BIRADS 2? Frankly speaking, the risk of malignancy in BIRADS 2 is 0%. It's nil. So here the options are 0 to 2%, 2 to 4, 10% and 50%. If we have to choose one option out of these, the option should be 0 to 2%. But the correct answer is actually it's 0%, means nil. There is no risk of malignancy in BIRADS 2. But for these four options, the best answer would be what? 0 to 2%. BIRADS is very important topic asked in surgery as well as radiology. So have the list of all the questions related to BIRADS. So first question, what is the full form of BIRADS? It's the Breast Imaging Reporting and Data System. If it's category 0 means incomplete assessment. And if there is incomplete assessment, additional imaging is required. You have to remember that it's 1 which is negative. It's 1 which is negative. And if findings are negative, routine mammography is recommended. Patient will come next year. And again here, the risk of malignancy is 0% in 1 and 2. What is 2? There is benign lesion. And if benign lesion is there, again routine mammography is recommended. Now here, category 3, probably benign. And if probably benign findings are there, in that case, short-term follow-up is recommended. And here the risk is 0 to 2%. For category 3 of BIRADS, the risk is 0 to 2%. Category 4 is suspicious abnormality. Here biopsy is recommended. It's further divided into 4A, 4B, 4C. 4A is there is low suspicion, 4B there is moderate suspicion, and 4C there is high suspicion. For 4A, the risk is more than 2 to 10%. For 4B, it's more than 10 to 50%. And for 4C, it's more than 50 to 95%. If it's 5, it's highly suggestive of malignancy. An appropriate action or intervention should be done. Here, can you see the risk of malignancy is more than 95%. And if patient is already having biopsy proven malignancy, that is category 6. Questions are asked that what is TIRADS, BIRADS, TIRADS, PIRADS. So BIRADS is the breast imaging reporting and data system. This is for breast based on which investigation? Mammography. Similarly, there is TIRADS, thyroid imaging reporting and data system. This is for thyroid. It's based on sonography. And there is PIRADS, that is prostate imaging reporting and data system. This is for prostate and this is based on MRI. This is very hot and these questions are nowadays frequently asked in exam. Now see this question. All of the following are indications for MRI in breast carcinoma except microcalcification, high-risk cases, breast implant patients, lobular carcinoma in situ. Before discussing question, have a look. Investigation of choice for screening of breast cancer is mammography, but investigation of choice for screening of breast cancer in high-risk females is MRI. What are those high-risk females? The females who are having BRCA mutation, or there is first degree relative with BRCA mutation, or there is family history of carcinoma breast, positive family history. Second, investigation of choice for diagnosis of complications in the patients who are having breast implant is again MRI. Lobular carcinoma in situ, ductal carcinoma in situ is going to increase tenfold. Breast cancer risk is tenfold. So here also the investigation of choice for screening is what? MRI. So let's have a look of one by one all the options. For lobular carcinoma in situ, it's correct. We will go for MRI. Breast implant, it's correct. High risk cases, it's correct. In cases of microcalcification, we will not go for MRI. You must be knowing that MRI is having poor sensitivity for calcification. That's why this is the correct answer for this question. There are two questions which are frequently asked. First, what's the most sensitive investigation for diagnosis of DCIS? The most sensitive investigation for DCIS, and that is MRI. Second question, most sensitive investigation for detection of microcalcification. So most sensitive investigation for detection of microcalcification in DCIS, and be careful, this is mammography. This is mammography. So these are the two questions which are frequently asked. Now have a look of American Cancer Society risk criteria for breast MRI screening. For breast MRI screening, what's the risk criteria? First you can see high lifetime risk. If there is high lifetime risk, how much? 20 to 25% or more. And what are those patients? BRCA1 or BRCA2 mutation, first degree relative with BRCA1 or BRCA2 mutation, lifetime risk of 20 to 25% or more than that, radiation therapy to the chest between 10 to 30 years, and Fmge and Cowden syndrome or first degree relative with Fmge or Cowden syndrome. So high risk, simultaneously Even moderately increased lifetime risk is also an indication for breast MRI screening. Here, can you see risk is 15 to 20%? There is all these are important. All these are important. Personal history of breast cancer, DCIS, LCIS, atypical ductal, atypical lobular hyperplasia. This was asked many times. In DCIS, LCIS, we discussed how much is the risk? Tenfold. Atypical ductal or atypical lobular hyperplasia, we discussed how much is the risk? Fourfold. And if the patient is having extremely dense breast or unevenly dense breast if viewed on mammography. So this is American Cancer Society risk criteria for breast MRI screening. What you have to remember, high risk mainly BRCA mutation, positive family history, Fmge or Cowden syndrome, or radiation therapy to the chest between 10 to 30 years. This question was asked in a latest exam, that what is the sensitivity of axillary ultrasound in identifying axillary metastasis in clinically node negative carcinoma breast, and the sensitivity of axillary ultrasound in axillary metastasis is 55 to 60%. Now see what DVITA says. Here you can see DVITA says that status of regional lymph node is one of the most important prognostic factor. Is one of the most important prognostic factor. But what is the most important prognostic factor? That is stage. If stage is not given in the option, then it's the axillary lymph node status. Ultrasound may add to the clinical examination and improve the sensitivity of node detection. And the combined sensitivity, can you see? The combined sensitivity ranges from 60 to 80%. It ranges from 60 to 80%. But surgical staging using ultrasound guided FNA or sentinel lymph node biopsy is required in all the patient. So here, what is the correct answer? It should be 60 to 80%. So for this question, it's 55 to 60%. There are certain changes in 8th AJCC TNM classification of breast cancer, and 8th AJCC TNM classification is very important for CA breast, for CA gallbladder, for colorectal cancer, for carcinoma stomach, and for head and neck malignancy, especially the oral cavity. 8th AJCC TNM classification is very important. It will be asked definitely. You have to remember the 8th AJCC TNM classification in surgery for these malignancies. Now, what are the changes in 8th AJCC TNM classification? Here you can see, according to 8th AJCC TNM classification, which of the following is not included in T4? Now see, invasion of dermis alone, which of the following is included? Now see the question. According to 8th AJCC TNM classification, which of the following is included in T4? Invasion of dermis alone in the breast, it's not included. Breast skins should be involved. Invasion of dermis alone is not included. Involvement of pectoralis muscle is not included. Why? Because pectoralis muscle is not the part of chest wall. What is T4A? That is involvement of chest wall. Chest wall is found by ribs, intercostal muscles and serratus anterior. So pectoralis major and minor involvement is not the part of T4, not the part of T4. Nipple retraction is not included, and here you can see involvement of intercostal muscle, which is the part of chest wall, and yes, it is included in T4A. So now have a look of T staging of breast cancer, 8th AJCC T, which is very important. Now in this case, everything is same. According to 7th, there are certain modifications. Now can you see T1 up to 2 cm, T2 more than 2 to 5 cm, T3 more than 5 cm, T4A extension to chest wall. Be careful, not including pectoralis muscle. Chest wall is composed of ribs, intercostal muscles and serratus anterior. Pectoralis involvement doesn't affect the stage in CA breast. T4B, edema, that is pudiorange, ulceration, satellite nodules confined to the same breast. T4C is T4A plus B, and T4D, inflammatory breast cancer. Now you have to remember this important list because this is very, very important. Invasion of dermis alone does not qualify as T4. Chest wall include ribs, intercostal muscles, serratus anterior, but not the pectoralis muscle. Now have a look of this one. Dimpling of skin, nipple retraction, other skin changes except those in T4B and T4D are not going to affect the classification. It can occur in T1, T2 or T3 without affecting the TNM classification. So this is very, very important, especially this list you have to remember. Now comes the question. A 45 years old male presented to OPD with breast lump of 4 cm in left breast. On examination, left axillary lymph node were fixed and matted. Which of the following is preferred treatment option? So how to crack the questions of breast cancer? First, what you have to do, derive the stage, and after deriving the stage, you have to go for the treatment. So what is the stage? If there is 4 cm lump in left breast, it is T2. What is T1? Up to 2 cm, T2 more than 2 to 5 cm, so T2. And left axillary lymph nodes are fixed and matted. This is what? N2A. And T2 N2A. What is the stage? This is 3A. The stage is 3A. And 3A is locally advanced breast cancer. And what is the treatment for locally advanced breast cancer? It's the neoadjuvant chemotherapy plus MRM plus radiotherapy. So let's have a look of treatment in breast cancer. If the patient is having early invasive breast cancer, what are the stages in early invasive breast cancer? 1, 2A, 2B. In these cases, preferred treatment is breast conservation surgery plus axillary lymph node sampling or sentinel lymph node biopsy plus radiotherapy. If there is any contraindication to breast conservation surgery, in that case we will go for what? Simple mastectomy. Simple mastectomy plus axillary lymph node sampling. Question: what's the treatment in locally advanced breast cancer? The stage is 3A, 3B and 3C. Here we will go for neoadjuvant chemotherapy plus MRM plus radiotherapy. And if the patient is having metastatic breast cancer, in that case hormone therapy is preferred over chemotherapy. Hormone therapy is preferred over chemotherapy. What are the indications of hormone therapy? ER/PR positive, asymptomatic visceral metastasis, bony or soft tissue metastasis. And if patient is having ER/PR negative, symptomatic visceral metastasis or hormone refractory tumor, in that case chemotherapy is used. So this is how we treat breast cancer. Always in the questions of breast cancer, derive the stage and then mark the correct treatment option. This question was asked in a latest exam that ixabepilon is used in which of the following tumors, and it is used in carcinoma breast. Ixabepilon is used in carcinoma breast. So you can see that ixabepilon is approved for breast cancer treatment. Now questions are asked regarding chemotherapy in carcinoma breast. So have a look of the questions. What is the chemotherapy regimen preferred? CMF or CAF? CMF is cyclophosphamide, methotrexate, 5-fluorouracil, and CAF is cyclophosphamide, adriamycin and 5-fluorouracil. Be careful, it's the adriamycin based chemotherapy or anthracycline derivative based chemotherapy is preferred. So it's CAF regimen. Certain patients who are having resistance to adriamycin. If the patient is having resistance to adriamycin, we give taxanes. And what are those drugs which are given? It's the docetaxel and paclitaxel. It's the docetaxel and paclitaxel. Third situation. Which drug should be given if the patient is having resistance to both adriamycin as well as taxanes? So if patient is having resistance to both adriamycin as well as taxanes, in that case we give what? Ixabepilon. Ixabepilon is given. There are certain other questions that what are the other new drugs given in carcinoma breast. There is another new drug known as lapatinib. Lapatinib is second line agent. It's the second line agent for HER2 new positive breast cancer. What is the first line agent? You must be knowing it's Herceptin or trastuzumab. Herceptin or trastuzumab. Second question, what's the indication of sunitinib in CA breast? So sunitinib is given in refractory metastatic breast cancer. It's given in refractory metastatic breast cancer where a patient is not responding to any other modality of treatment. And two questions are asked regarding hormone therapy, drug of choice for hormone therapy in CA breast. If nothing is mentioned, go for tamoxifen. Specifically mentioned premenopausal, go for tamoxifen. How much is the dose of tamoxifen? 10 mg BD for 5 years. And the second question, drug of choice for hormone therapy in postmenopausal patient, and here we give what? Aromatase inhibitors. So these are the frequently asked questions related to the drugs given in carcinoma breast. Now see the question, it was asked in a latest exam. A 36-year-old patient underwent breast conservation therapy and chemotherapy for 1.5 into 2 cm ER positive breast cancer with 1 positive axillary lymph node. She is now on tamoxifen because ER is positive, so we are giving hormone therapy. How you will follow up this patient? How will you follow up? Now in this case, annual bone scan, no. Assessment of tumor marker 6 monthly, no. Routine clinical examination 3 monthly in first year with annual mammogram. And D, routine clinical examination 3 monthly and 6 monthly liver function test. Out of these 4, the preferred answer is C. That is, we have to go for routine clinical examination 3 monthly in first year and annual mammogram. Now see what Bailey says regarding follow-up. So here you can see, patients with breast cancer used to be followed for life to detect recurrence and dissemination. This lead to large clinics with little value for either patient or doctor. So it is current practice to arrange yearly or 2-yearly mammography of treated and contralateral breast. There is move to return the patient early to the care of general practitioner with fast track access back to the breast clinic if suspicious symptoms appear. There is no routine role for repeated measurements of tumor markers or imaging other than mammography. Can you see? There is no routine role for repeated measurements of tumor markers or imaging other than mammography. So that's why you can see what? That these two are incorrect. Even the D option is incorrect and the correct option is C. So nowadays questions are asked about follow-up. So let's see how we are going to follow up a patient of breast cancer. Now, in breast cancer follow-up, history, physical examination every 3 to 6 months for first 3 years. After that, every 6 to 12 months for 4 and 5 years annually thereafter. Mammography annually, beginning no earlier than 6 months after radiation therapy. So it should be at least after 6 months of radiation therapy. Breast self-examination, they should perform monthly, pelvic examination annually, and there should be coordination of care with breast cancer specialist and other healthcare providers. Now have a list of this one. Not recommended for routine surveillance. So see, routine blood test. In the question it was mentioned LFT, blood count, not recommended routinely. Imaging studies, chest x-ray, bone scan, it was mentioned in the question, not recommended routinely. Ultrasound, CT, FDG, PET, breast MRI, not recommended for routine breast cancer surveillance. And can you see tumor markers? Cancer antigen, CEA, not recommended. So this is how we follow up the breast cancer. You have to remember that these are not recommended for routine surveillance in breast cancer patients. Now see this question. Adjuvant therapy after mastectomy is needed in all of the following except high risk node positive, low risk no node, ERPR negative, HER2 positive. Let me tell you one thing. Adjuvant therapy after mastectomy is needed for the patient who are having adverse prognostic factors. What are those adverse prognostic factors? It's high histological grade, high histological grade, lymphovascular invasion, lymphovascular invasion, or adverse prognostic factors, patient who is lymph node positive, patient is ERPR negative, HER2 positive. So all these are adverse prognostic factors in which adjuvant therapy is needed. Now can you see in this question, if the patient is high risk node positive, yes, we will go for adjuvant therapy. ERPR negative, yes, we will go for HER2 positive, we will give adjuvant therapy. But if patient is low risk and there is no node, in that case, adjuvant therapy is not required. So for this question, what is the correct answer? It's B. This question was asked in latest exam 2 to 3 times. Van Nuys classification does not include which of the following? And here the correct answer is HER2 receptor status. So what is this Van Nuys prognostic index? This prognostic index was designed for the patients who are having DCIS, ductal carcinoma in situ, and after resection of tumor, which patient will not require radiotherapy. Means after tumor resection, which patient will not require radiotherapy. This prognostic index is for patients of DCIS who does not require radiotherapy. It is based on mnemonic is SWAG. What is the full form of SWAG? Size, width, width of margin, age, and grade. Simultaneously, microcalcification. Microcalcification. So the mnemonic is actually microswag. It's the microswag. This is how you will remember. So here you can see age is there, size is there, presence of microcalcification, yes, it's there. HER2 receptor status is not included in Van Nuys prognostic index. This is very, very important. You have to remember what are the components of Van Nuys prognostic index. Mnemonic is microswag, microcalcification, size of tumor, width of resection or width of margin, age of the patient, and grade or tumor grade. This question was asked many times that what's the most common complication of mastectomy, and let me tell you the answer depends on the options provided. Long back this question was asked in one of the latest exam and one of the option provided was seroma. Actually speaking, the most common complication of mastectomy is what? Seroma. It is seen in up to 30% patients. But see, seroma is not mentioned. Here, angiosarcoma, very rare. Thoracodorsal palsy, very rare. Long thoracic nerve palsy, it's also not very common. Out of these four, which one is more common out of these four? It's the intercostobrachial nerve palsy. This question was also asked indirectly that in sentinel lymph node biopsy, what is the most commonly injured nerve? Again, answer is same, intercostobrachial nerve. So two questions. Here also the correct answer is intercostobrachial nerve palsy, and most commonly injured nerve in sentinel lymph node biopsy is intercostobrachial nerve palsy. Now the question is asked, what's the best myocutaneous flap for breast reconstruction? It's one of the type of tram flap which is most commonly used, and here the correct answer is transverse rectus abdominis muscle flap. Suppose one of the option is DIEP flap. Suppose one of the option is DIEP flap, then the correct answer would be DIEP, deep inferior epigastric artery perforator flap. So here the correct answer is transverse rectus abdominis muscle flap or tram flap. See the methods of breast reconstruction, how we perform breast reconstruction. There are three methods of breast reconstruction. First, autogenous. Second, alloplastic. And third is combined method. In autogenous, we are using patient's own tissues. Most commonly used flap is tram flap. Another commonly used flap is what? LD flap. In alloplastic, we are using silicone implants. Silicone gel implant or silicone implants with saline refill. And in combined method, the patients who are having large breast, in that case, we are using what? Tram flap plus implant, or LD flap, we are using LD flap plus implant. So tram flap plus implant or LD flap plus implant. Questions are asked if we are, what is the most commonly used method of breast reconstruction? Question is asked that what is the most commonly used method of breast reconstruction worldwide? See, most common method of breast augmentation as well as breast reconstruction is what? Silicone implants. And for silicone implants related complications, what is the investigation of choice? It's MRI. So these are the questions which are frequently asked. So see this question, in inflammatory carcinoma breast with metastasis to axilla, what's the treatment of choice? So have a look of inflammatory breast cancer. What's the other name of inflammatory breast cancer? It's also known as mastitis carcinomatosa. What is the stage? It is T4D and it corresponds to which stage? Stage 3B. If it is T4D which corresponds to stage 3B, 3B means locally advanced breast cancer. What's the problem in mastitis carcinomatosa or inflammatory breast cancer? Breast cancer appears like some inflammatory disease of breast like breast abscess. Why? Because inflammatory changes are there in breast skin. So how much breast skin is involved by inflammatory changes? This is the question. At least 33%. So when at least 33% of breast skin is involved by inflammatory changes, that is brani induration, erythema, pudgy orange. In this case, the presence of lump is not mandatory. So if the presence of lump is not mandatory in this case, how we are going to confirm the diagnosis? We have to perform skin biopsy. Why? What is the cause of early onset of pudgy orange? There is early lymphatic permeation by tumor cells. Can you see? The tumor cells are going to obstruct the cutaneous lymphatics. So early permeation of cutaneous lymphatics leading to early onset of pudgy orange, and that leads to early onset of lymph node metastasis and early distant metastasis. That's why patients of inflammatory breast cancer at the time of presentation, 75% patients have axillary lymph node metastasis, 25% patients have distant metastasis. So if you see the stage, it's locally advanced breast cancer. What is the treatment of locally advanced breast cancer? It's neoadjuvant chemotherapy plus MRM plus radiotherapy. So what is the correct answer for this patient? This is the correct answer. Neoadjuvant chemotherapy plus MRM plus radiotherapy. Now see this question, which of the following is true? Which of the following is true about male breast cancer? Invasive lobular carcinoma is the most common type. This is wrong. Now see, what is the difference in females and male breast? In females, there is both duct as well as lobules. In males, only duct is there. That's why invasive ductal as well as invasive lobular carcinoma is seen in females. But it's only invasive ductal cancer which is seen in males. Lobular carcinoma is exclusively seen in females because they have lobules. It is not seen in males. So what? This is incorrect. ER is negative. It's incorrect because ER/PR in both males and females is positive in 80% cases. ER/PR is positive in both male and female breast cancer in 80% cases. It is seen in young males. This is wrong because it is seen in sixth decade, and BRCA2 mutation increased is associated with increased risk. This is correct. Now see, BRCA1 located on chromosome number 17, BRCA2 located on chromosome number 13. Both BRCA1 as well as BRCA2 are going to increase the risk of breast cancer in both females and males. But which one is mainly responsible in females and which one is mainly responsible in males? How to remember? The mnemonic ladies first. It means BRCA1 is responsible for increased risk of breast cancer mainly in females and BRCA2 in males. So for this question, correct answer is D, that BRCA2 mutation is associated with increased risk.